First of all, I would like to thank the organizers for giving me this opportunity to deliver this talk. Today, I am going to talk on a very important and very needy topic, that is CTD-associated interstitial lung disease. Interstitial lung disease is a common manifestation of connective tissue diseases, and it can, it can involve many CTDs, but most commonly it includes rheumatoid arthritis, systemic sclerosis, and inflammatory myopathies. CTD-ILD is defined as evidence of interstitial lung disease, which is demonstrated by CT scan when HRCT shows a combination of reticulation, ground glass opacification, traction bronchiectasis, honeycombing, or cyst in the setting of an established connective tissue disease. So before diagnosing a patient with connective tissue associated ILD, other causes of parenchymal lung diseases in CTD needs to be ruled out. And these conditions include infection, drug-induced lung disease, malignancy, idiopathic interstitial lung diseases. So now I am going to discuss these entities one by one. First of all, rheumatoid arthritis associated interstitial lung disease. As you all know better that rheumatoid arthritis can involve lung in many different ways. It can cause pleural effusion, it can cause pulmonary nodules, pulmonary hypertension, but interstitial lung disease is most common manifestation of rheumatoid lung disease. Rheumatoid arthritis is one of the most common CTDs in Western world, especially in the United States. It is seen in 0.5 to 1% of population. If we talk about prevalence of interstitial lung disease in rheumatoid arthritis, it is seen in, according to different studies, from 10 to 50% of the patients with rheumatoid arthritis may develop rheumatoid-associated interstitial lung disease. So, risk factors. The risk factors to develop rheumatoid-associated interstitial lung disease include more severe rheumatoid arthritis, high C-reactive protein, male gender, elderly patients, patients with obesity, history of cigarette smoking, those patients who have severe extra-articular disease, and exposure to fine particulate matter. The most common histopathological pattern among the patient with rheumatoid-associated arthritis ILD is usual interstitial pneumonia, and other common histopathological pattern is non-specific interstitial pneumonia, while other pathological patterns like organizing pneumonia, lymphoid interstitial pneumonia, or diffuse alveolar damage, these can also occur, but these are rarely seen in patients with RA-associated ILD. Most common pattern is UIP or NSIP pattern. Now, talking about the clinical presentation. Symptoms of rheumatoid arthritis-associated ILD typically include insidious onsets of dyspnea and non-productive cough, while fever, chest pain, and acute symptoms are usually less common. They may occur when patient is having an exacerbation, but usually these symptoms are less common. Differential diagnosis of RA-associated ILD include ड्रग-इंड्यूस्ड लंग डिजीज़. ऐसे कोई पेशेंट ऐसी ड्रग ले रहा है जिसके साथ rheumatoid लंग में इंटरस्टिशियल चेंजेस आ सकते हैं, लाइक मीथोट्रेक्सेट, इन्फेक्शन, हार्ट फेलियर, recurrent gastroesophageal aspirations, malignancy, and idiopathic ILDs. So before labeling a patient with RA-associated ILD, we have to rule out these entities. So how to reach the diagnosis? The diagnosis of RA-associated ILD is generally based on combination of clinical presentation, pulmonary function test, high-resolution CT scan findings. Lung biopsy is rarely needed, and if it is required, only in selected patients. These lung biopsy usually performed when patient present with a rapid progression, fever, predominance of ground glass opacification, And before going for a lung biopsy, one should perform bronchoscopy and take bronchoalveolar lavage sample to rule out any infection. So this is a chest CT, which is basically showing NSIP pattern, which shows ground glass specification, reticulation, interseptal thickening. So this is NSIP pattern with predominance of ground glass specification. इस पैटर्न को देखना ट्रीटमेंट के लिए बहुत इम्पॉर्टेंट है, इसको समझना ज़रूरी है. This is another pattern. This is called UIP pattern. Here you can see patient is having honeycombing stack of cysts, छोटे cysts की stack बन जाती है, peripheral, subpleural, basal, और इसमें आप देख रहे हैं कि इसमें ग्राउंड ग्लास स्पेसिफिकेशन कम है, इस पर सेलुलैरिटी कम है, फाइब्रोसिस हो चुकी है. तो दिस इज अनदर पैटर्न विच इज़ कॉल्ड UIP पैटर्न. सो दो पैटर्न HRCT में कॉमनली देखे जा सकते हैं. अब नेक्स्ट है हाउ टू अप्रोच फॉर ट्रीटमेंट. ट्रीटमेंट इज डिटरमाइंड बाय सेवेरिटी ऑफ इम्पेयरमेंट, रेट ऑफ प्रोग्रेशन एंड रेडियोग्राफिक एंड और हिस्टोपैथोलॉजिकल फाइंडिंग, अगर UIP पैटर्न है या NSIP पैटर्न है. सो वी कैन स्ट्रैटिफाई और एसोसिएटेड ILD. फॉर ट्रीटमेंट पर्पस हम उसको डिवाइड कर सकते हैं कि माइल्ड इंटरस्टिशियल लंग डिजीज़ और स्टेबल फाइब्रोटिक डिजीज़, more severe or progressive disease without predominant fibrosis, more severe disease with fibrosis, और दूसरा यह है कि worsening of these non-fibrotic and fibrotic diseases despite the treatment. So a patient who are asymptomatic and those who have mild ILD, it means they have mild dyspnea or cough with vital capacity, lung volumes and diffusing capacity more than 70% of predicted. So in this scenario, it is recommended just a clinical follow-up and surveillance with PFTs. हम PFTs को देखेंगे, HRCT बार बार इन केसेस में नहीं करेंगे. PFT को देखेंगे, अगर डिटीरियोरेट हो रहा है तो then we can go for HRCT. Similarly, for patients with UIP pattern and stable disease by symptoms, PFT and HRCT, in this case also it is recommended only monitoring, clinical monitoring along with PFTs. While initial therapy for more severe or progressive disease without predominant fibrosis. In this case, anti-inflammatory therapy with steroid-sparing agents like mycophenolate or rituximab rather than an upfront anti-fibrotic therapy. अब इधर एक बात बड़ी इंपॉर्टेंट है कि जो ट्रीटमेंट है इट शुड बी डिसाइडेड बाय rheumatologist एंड pulmonologist, क्योंकि पेशेंट को एक्स्ट्रा पल्मोनरी डिजीज़ भी है तो जिसको rheumatologist बेहतर जानता है. तो इट शुड बी जॉइंट डिसीजन बाय rheumatologist एंड pulmonologist. और दूसरी एक बहुत इंपॉर्टेंट पॉइंट है कि देयर आर नो गाइडलाइंस नहीं है इनको ट्रीटमेंट की. देयर आर डिफरेंट केस सीरीज़ जिसकी बेस पे ये ट्रीटमेंट वो जो है अवेलेबल है. इनिशियल थेरेपी फॉर मोर सीवियर और प्रोग्रेसिव डिजीज़ विद प्रीडोमिनेंट फाइब्रोसिस, जहाँ पे फाइब्रोसिस नहीं है वहाँ पे आपने एंटी इन्फ्लेमेटरी दे रहे हैं. एंड व्हेन पेशेंट डेवलप्स फाइब्रोसिस, इन दैट केस द चाइल्ड शुड बी गाइडेड बाय total immunosuppressive burden engendered by add-on therapy, the need of additional immunosuppression to treat extrapulmonary disease, and the extent and progression of pulmonary fibrosis. ये वो चीज़ें हैं जिनको हमने देखना है before initiation of any therapy. So in this case, either addition of a steroid-sparing agent or initiation of anti-fibrotic therapy with nintedanib, rather than an expected management or treatment with glucocorticoids alone. वो patient who are younger and presents with a worsening of symptoms, PFTs or HRCT over preceding 3 to 6 months, they are going to be benefited by anti-inflammatory therapy. जो लोग यंग हैं उनमें अगर आप एंटी इन्फ्लेमेटरी देंगे तो वो बेनिफिट होंगे, अदरवाइज आपको nintedanib का यूज़ करना है. Few words about nintedanib. Nintedanib, it is an tyrokinase inhibitor which shown effective against IPF treatment. It is approved by FDA based on results of in-built trial for all patients with progressive fibrosing interstitial lung disease. But the cost and side effects and other thing is availability may limit the use of nintedanib. Pakistan में उस तरह freely अभी available नहीं है nintedanib, unfortunately. Indication of nintedanib इसमें मैं थोड़ा बताना चाहूँगा. Fibrosing interstitial lung disease, which include CTD-ILD, with one of the following criteria in prior 24 months. A relative decline in forced vital capacity more than 10% of predicted value, or a relative decline in forced vital capacity of 5 to 10% and either worsening in respiratory symptoms or increase in extent of fibrosis on high resolution CT chest, or worsening in respiratory symptoms and increase in extent of fibrosis on HRCT. तो इनमें से अगर कोई भी एक present हो along with fibrosing ILD, these patients are candidate to receive nintedanib. Initial therapy. Next, initial therapy for fulminant disease. For patients who present with fulminant interstitial lung disease after excluding infection and drug-induced lung toxicity, so it is recommended to start the initial high-dose systemic glucocorticoids. Adjunctive therapy includes cyclophosphamide and rituximab, which may be used in addition to glucocorticoids on case-by-case basis. Next group is if patient develop worsening of non-fibrotic ILD despite initial therapy. So in this case, typical approach is add or change the disease-modifying anti-rheumatic therapies. While patient who develop progressive fibrosing interstitial lung disease despite initial therapy, in this case, either we have to add, if patient is not getting nintedanib, we have to add an nintedanib along with anti-inflammatory drug. So next step is how to monitor the treatment with these drugs. Monitoring of the disease activity includes clinical assessment of the patient, HRCT chest, pulmonary function test, and surveillance of the adverse effects of immunosuppressant therapies. Now, prognosis of RA-associated ILD. Risk factors of disease progression and mortality include older age, UIP pattern on histopathology or chest imaging, decreased pulmonary function, and acute exacerbation of interstitial lung disease. These are the factors which lead to poor prognosis of RA-associated ILD. So this is all about RA-associated ILD. Next entity is interstitial lung disease, which is associated with systemic sclerosis. Pulmonary involvement occurs in about 80% of patients with systemic sclerosis. Interstitial lung disease and pulmonary arterial hypertension are most frequent and major types of lung involvement. The prevalence of interstitial lung disease approaches 50% of patients with diffuse cutaneous systemic sclerosis. Risk factors to acquire systemic sclerosis associated interstitial lung disease include positive anti-SCL70 antibodies, black race, or higher skin score. Early systemic sclerosis associated ILD may be asymptomatic, but common symptoms of this ILD include fatigue, shortness of breath, and dry cough. Chest pain is usually infrequent and hemoptysis is rare. So diagnosis, as other ILDs, the diagnosis of systemic sclerosis ILD is established on the basis of clinical presentation, HRCT findings, and usually lung biopsy is not required to reach the diagnosis, and we have to exclude the other causes which may cause interstitial lung disease. HRCT findings in systemic sclerosis typically shows NSIP pattern. As I mentioned earlier, NSIP pattern means patient is having ground glass opacification, interseptal thickening, and reticulation. But if patient have more advanced disease, reticular opacities increase and patient may develop traction bronchiectasis, which result in volume loss. So these are few features which are associated with increased likelihood of disease progression in systemic sclerosis. So it includes the disease duration less than 4 years, diffuse cutaneous systemic sclerosis, pulmonary function test which include forced vital capacity less than 65% are predicted, and DLCO of less than 55% are predicted, while interstitial lung disease affecting more than 20% of the lung, and patient have anti-SCL70 antibodies are positive. So these are features which are associated with disease progression in systemic sclerosis. Now treatment. For the patient with systemic sclerosis associated ILD who have respiratory symptoms, abnormal or declining pulmonary function test, and imaging evidence of ILD with no evidence of acute infection, treatment is recommended with mycophenolate mofetil as an initial therapy. Tocilizumab and cyclophosphamide are reasonable alternative in some selected patients where mycophenolate cannot be given. Mycophenolate is administered orally, gradually in increasing doses to enhance the gastrointestinal tolerance with a target dose of 1.5 to 3 gram daily in 2 divided doses, while tocilizumab 162 milligram weekly by subcutaneous injection. If we administer cyclophosphamide, it is administered via monthly intravenous injection for 6 months or via daily oral dosing for 12 months. The duration of mycophenolate mofetil is not well established in patients with systemic sclerosis associated ILD. Maintenance treatment is continued usually at least for 24 months and often for several years. For those patients whose disease shows progression despite the above measures, it is suggested to add nintedanib in the treatment or rituximab in ongoing therapy. Next common condition, connective tissue disease, which may cause interstitial lung disease, is dermatomyositis or polymyositis. ILD occur approximately in 60 to 80% of patients with dermatomyositis and polymyositis. Disease may present as chronic and slowly progressive or acute with rapidly progressive disease. Several histological patterns are usually same. इनमें जो आर्य एसोसिएटेड ILD है वहाँ UIP ज़रा कॉमन है, बाकी जो टाइप्स है वहाँ NSIP कॉमन है, UIP रेयरली है in these conditions. So NSIP is most common, followed by organizing pneumonia, then diffuse alveolar damage, and rare one is usual interstitial pneumonia. Clinical presentation is also same like all other interstitial lung disease. It includes shortness of breath, non-productive cough, or some patients may remain asymptomatic in early course of the disease. Diagnosis, as in other CTD-associated ILDs, is based on clinical presentation and on HRCT imaging. Lung biopsy is rarely required. So, if patient is having mild disease, in that case only required observation and serial PFTs. But if patient has a progressive disease, in that case we have to start treatment with prednisolone 1 milligram per kilogram body weight and maximum daily dose up to 80 milligram. For patients with rapidly progressive disease leading to high oxygen requirement, like patient presents in emergency with an oxygen demand of 10 liters per minute and may need ventilatory support. In this case, it is recommended to addition of intravenous immunoglobulin to high dose intravenous glucocorticoids due to rapid onset of action. और इसमें फिर ऐड ऑन बाद में रोटिक्सिमैब एंड साइक्लोफॉस्फामाइड और टोसिलिज़ुमैब आप कर सकते हैं एज ए स्टीरॉयड स्पेयरिंग एजेंट्स। अब मुझे ये एक मिल गया कि 5 मिनट्स रह गया, मैं जल्दी कुछ आपको ये बता दूं कि SLE में भी पेशेंट मे प्रेजेंट विद इंटरस्टिशियल लंग डिजीज़। इसमें भी कॉमन पैटर्न NSIP है, UIP इसमें भी रेयर है। और ट्रीटमेंट ऑफ चॉइस स्टार्टिंग विद प्रेडिसलोन, और अगर इससे रिस्पांस नहीं कर रहा तो देन वी हैव एन ऑप्शन टू ऐड एजोथाइप्रीन, माइक्रोफिनोलेट एंड रिटुक्सिमैब। इफ़ ILD इसमें रेयरली UIP पैटर्न में जाता है SLE एसोसिएटेड ILD में, बट इफ पेशेंट वेल UIP पैटर्न और फाइब्रोटिक NSIP, इन दैट केस वी कैन ऐड निंटेडिनेब इन दोज पेशेंट्स। ये मैं 2 स्लाइड ज़रूर शेयर करना चाहूँगा। एक टर्म है इंटरस्टिशियल निमोनिया विद ऑटो इम्यून फीचर्स। कई मरतबा हमारे पास पेशेंट आते हैं और हम कह रहे होते हैं कि जी ये पेशेंट जो है ना, ये तो र्यूमाटोलॉजी वाले देखें, ये तो इसमें है र्यूमाटोलॉजी, लेकिन वो उसके ना डायग्नोसिस के क्राइटेरिया पे फिट ऑन नहीं होता। तो अमेरिकन कॉलेज ऑफ थोरेसिक, अमेरिकन थोरेसिक सोसाइटी और यूरोपियन रेस्पिरेटरी सोसाइटी ने दे हैव launched another term, that is interstitial pneumonia with it autoimmune features. So this is a different entity which is not fit in rheumatoid associated या CTD associated ILDs. So the term allows to standardization of diagnosis so that these patients can be further studied. NSIP and UIP are the most common radiographic patterns in these patients, and treatment decision are based on clinical evaluation, as there is no randomized clinical trials of treatment of this population. ये एक टेबल है जिसमें वो कॉमन मेडिसिन है, स्टीरॉइड्स, माइक्रोफिनोलेट, एजोथाइप्रीन और टोसिलिज़ुमैब, जो हम कॉमनली यूज़ करते हैं टू ट्रीट द पेशेंट विद CTD एसोसिएटेड ILDs. So few adjunctive therapies ये सब ILDs में कॉमन है, लाइक ऑक्सीजन थेरेपी। जो पेशेंट ILDs के साथ होते हैं एट सम टाइम दे मे रिक्वायर ऑक्सीजन थेरेपी। एनी पेशेंट हु इज़ नॉट मेंटेनिंग सैचुरेशन एट रूम एयर और आफ्टर एक्सरसाइज और ड्यूरिंग स्लीप, so we should prescribe oxygen therapy to maintain his saturation around about 88%. Pulmonary rehabilitation is very important, इससे exercise tolerance बेहतर होती है। और last one is vaccination. All the patients with interstitial lung disease should receive annual influenza vaccination along with pneumococcal vaccination, ताकि उनको इस तरह की डिजीज़ इन्फेक्शन से बच सकें वो, और इनकी एक्सरबेशन ना हो ILDs की। बस लास्ट स्लाइड है, लंग ट्रांसप्लांटेशन। Lung transplant should be considered in all patients with disease that progress despite the therapy. In general, outcomes with transplant in CTD-ILD are similar to outcomes with other interstitial lung diseases. Thank you very much for patient listeners.